Hello, it's that time again. Facebook Live Q&A. I've got some questions here. If you have any questions you want to join in, then feel free to ask away. If you're wondering who I am, Jonathan Stoiano is my name, consultant plastic surgeon, and I have got a YouTube channel, the Stoiano Clinic, so you can find my videos there. And this goes on a podcast on iTunes as well. So feel free to comment and share if you have any views, and if you have any questions, feel free to ask me here live. But I do have some questions that have been asked in the week, so I will crack on with those to start with. And first of all, I haven't put it up as one of the little questions on there is, do we do dental implants? The answer is no, we don't do dental implants. When I first started the clinic, there was an orthodontist who came and looking into sort of renting the space, but he wanted to have the whole top floor and sort of take over a bit, and we'd have to get quite a lot of dental equipment. So the answer is no, we don't do dental implants. But yeah, breast implants, yeah. Dental implants, no. So see the chat. Hi Olivia, good to see you. Couldn't see the chat. Is the chat there? I hope the chat's there. I don't know what you normally see. Is it different to what you normally see? I normally do a scheduled post, and this is I'm just doing this straight off, so maybe it's a bit different. So how far round do they go with a tummy tuck? Does it lift your side of apron? So no, the tummy tuck is really good at the front bit. It does go quite far to the sides. A tummy tuck, a scarf, my tummy tuck goes from hip to hip, so sort of hip bone to hip bone, your anterior superior iliac spine, that bony prominence that you have at the front of your pelvis. So it goes from hip to hip. So it is quite a long scar. It goes across the whole front of your abdomen, and sometimes it can go further than that. But what you've got to realize with a tummy tuck, if you have a look at the skin that is removed, if you look at the pattern of skin that's removed, it's an elliptical shape. So it's very tall at the middle where your belly button is, and then it peters out towards the sides. So the real focus of a tummy tuck is your central abdomen, around where your belly button is. The effect that it has on your sides, your hips, your flanks, your sides, and what you call the side apron gets limited the more you go out to the side. So you can take more out from the sides by going longer. Now you're limited as to how you know where you're positioned on the operating table, because you're lying on your back. So you're limited as to how far back you can go. But even when you do go to the sides, it is slightly more limited how much you can go to the sides there. So if you want to have those sides bits addressed, the lateral bits addressed, the best way to address those, well, there's two ways. First of all is with liposuction, which is probably the commonest way. So you can combine a tummy tuck with liposuction to those side bits to get a nice contour to the side bits, and they respond well to liposuction. The hips, the flanks responds well to liposuction to contour and give a better shape. If you have got a significant, as you say, side opening, you've got a lot of skin there at the sides, then the best way is what is a 360-degree tummy tuck to go all the way around. So you might think that going all the way around is because you want to get the back tightened, and it does take some skin off the back, circumferential tummy tuck, because you do take some of the back. But where it really has a dramatic effect is on those side bits. If you look at how much is taken on the side bits when you do a 360-degree tummy tuck versus a traditional tummy tuck, it's like that on a traditional, that on a that on a 360-degree, because you don't need to peter into a point to sort of prevent that dog ear. So if you have a significant, but a 360 degrees is a massive operation. It's only for people who had a massive weight loss. But that's probably the best way to contour the side bits. Failing that, liposuction. Failing that, nothing. Some people don't need liposuction. If you don't have anything, I know, we'll give you advice and say, look, you know what, I don't think you need liposuction or whatever. But we can't address those side bits with a tummy tuck, and it's all about being informed pre-op. Because if you're not having liposuction and you're just having a standard tummy tuck, it's limited how much contouring, you can get to those side bits. And it's about being aware of that pre-op so you're not unhappy afterwards. Sometimes people say, what have you done? What have you put here on my sides? I haven't put anything there. It's just that when you got rid of the apron at the front, the side bits can look a bit more prominent. So it's about being aware of what's possible. Tracy says hi. Hi, Tracy. Olivia says, doctor here told me it was pointless me having tummy tuck just before surgery. I didn't think I had much at sides. He lifted up skin at sides and back. Pointless having tummy tuck just before surgery. I didn't think I had much at sides. He lifted up sides and back. Okay. Yeah. Not sure what that. Yeah. I mean, to be honest with you, all this stuff that I'm saying is just me saying stuff. And if you've seen a doctor, plastic surgeon who's given you a view, I go with what they said because they've seen you in person. If they're giving you advice, they're probably better than me just giving you general, just giving general views here. But no substitute for an in-person consultation. Sarah, big up yourself. How you doing, Sarah? Nice to see you here tonight. Is the recovery on a 360? Yes, Sarah. It's a monster, a 360. It's a big deal. It's got a much higher complication rate. You've got tension on the back, tension on the front. It's a big deal, Sarah. It's significantly so, I would say. It's a bigger operation than a standard tummy tuck, and something that's only rarely needed, to be honest with you. And it's difficult because you have to go all the way around the back, so you have to change position while you're in theatre, while you're anaesthetized, which is never great. So it's a big deal. Olivia says Wi-Fi gone. Now that's pretty impressive that you're actually posting Wi-Fi gone, because don't you need Wi-Fi to post that? But anyway, well done somehow getting the post out that your Wi-Fi's gone. Maybe that went just before the Wi-Fi had gone. Olivia's in the house. Could you have liposuction at the same as a tummy tuck? Yes, you can, Olivia, and it's quite common to have liposuction, especially to those side bits, those hips, the flanks, the side bits, to contour those side bits. That's quite common. What sort of face is that, Sarah? What's that? Is that a thinking face? Looking up? I don't know. Not all right. So I'm not really good on the emojis. I am a big fan of the emojis, actually. Having said that, and a bit of aficionado. How do I get compression garment on my arms if I'm alone? Well, two things. This is compression garment general and arms. Double prong question. We've got a two-pronged attack on this one. So first, compression garments in general. How do I get a compression garment if I'm on my own? Answer: very difficult / nigh on impossible, depending on what sort of garment it is. If you have a compression garment, what we normally do, and this is a patient who's had surgery elsewhere who's asking, I mean, what we would normally do is try and get the nurse to do the pressure garment with you before you go, if you're going to be taking it off, just to check that you're comfortable taking it on and off. But to do it on your own is very hard, and it's actually sometimes hard for us to do it. For you need two people to do it. It's a two-man job. And it is a two-man job, and it's difficult when it's a two-man job with not you involved. So therefore, three-man job. Two people apart from you, if that makes sense. Well, as you, you're obviously there because you're wearing the garment. But you could do it as a two-man job with you being one of the men / women. So you could do it with yourself, and you hold it, and the other person hooks it over. But to do it on your own, so certainly in the early post-op stage, is really hard / impossible. Of course, it makes it difficult to wash and things if you're on your own. I understand that, but that is a difficult thing to do. Oh, and the other thing was arms. Sorry, I'm being distracted. The other thing is arms. Compression garment on the arm. Now, personally, for an arm lift, I don't use a compression garment. I think compression garments are good. I think they are good for support. They help with swelling. They make things comfortable, and they are good things. And I use them for tummy tucks. I use post-op bras, which is sort of like the compression for breast surgery. But I don't. But they're for comfort. And arms, I find it difficult. The problem with a compression is where the compression ends. The compression has to end somewhere, and you run the risk of getting swelling past where that compression ends. So it's hard to get compression on an arm. So if you're doing surgery on an arm, if you put a compression garment on, if it sort of ends mid forearm, you might get swelling distal to that. You might get swelling past it if it ends here. So ideally, you'd cover it up to sort of a glove, but then that's a massive compression garment if you go all the way up to your hand. Similarly, and probably more importantly, why I don't use a compression garment when I do an arm lift. When I do an arm lift, I have a straight line scar, and there's also an extension into your armpit. And if the compression garment ends in that armpit, it can make it worse. It can irritate your scar, and it can make the swelling worse past where the compression ends. So I find it really hard to get good compression on the arm. And I find the problem with compression garments is where it ends, where they begin and end. You get swelling past them, and it's a particularly problem with the arm because obviously you've got to move your elbow and you oh, that's your elbow, isn't it? It's got to move your shoulder. You've got to move your shoulder and stuff. So you can't sort of be in a plaster cast. You have to move. So it's hard to get the compression up there into the armpit. So therefore, I don't use it. So another question which I also haven't put on there, like, isn't compression essential and things? It isn't essential. It's for your comfort. It does help with swelling, but if it's uncomfortable, if it's digging in, if it's giving you red marks, again, this is my view. I'm like, well, you don't have to use it. Sometimes men, when they have gynecomastia, the compression garment digs onto the armpits and things. As they wear one of those t-shirts, those tight t-shirts. Women with the post-op garment for an abdominoplasty sometimes find them uncomfortable digging in and what have you. So I'll say, look, wear big pants, the big supportive pants instead. Just wear something else. You don't have to be too prescriptive about it, and you don't. Well, again, in my view, because you get my disclaimer up. In my view, I think it's more important that you are comfortable than you have some compression garment that is sticking in, digging in, causing red marks, worst case causing ulceration. They can cause problems. And so I don't think it is the be all and end all. And if it's digging in, if it's uncomfortable, try something else, or perish the thought, maybe do without it. That's what I would say. If you're my patient, you're not my patient, so you better stick with what your surgeon says. But this is my view on the compression garments. They're for your comfort, and they're for your support. They're not actually compression. They're not supposed to be when you take them off, you think, oh my God, you breathe a sigh of relief saying that's it. I feel so much better. If that's the case, I would say, look, they're probably a bit too tight, certainly if they're leaving red marks and things. So that is my view on it. But if you have had surgery with someone and they've said, look, you've got to wear the compression garment, it's absolutely essential, you can have a disaster if you don't, then you better do what they say, don't do what I say, because we've all got different views on this sort of thing. Sarah says, have you seen my love? Oh, matron. Terry, I think that's a clap. Big up yourself, Terry. Big winner last week. Was it last week or the week before? Terry's in the house. Gemma's here. Evening, Gemma. Olivia's got the Wi-Fi on and off, hence the comments. We've got the Olivia sisters in tonight because we've got the Olivia Pemberton and we've got the Olivia Stilton. How many surgery can you have at one time? That's Sister Stilton saying that. That's a funny question, Olivia. How many surgeries can you have at one time? What, are you going for the Guinness World Record or something? How many do you want? I mean, you can do a lot of stuff to people. You have a road traffic accident, you break lots of bones. You come in theatre for hours having bones fixed, having, brain hemorrhage sorted out, heart contusion fixed, lungs, liver laceration. You have it all done because you have to have it all done in one go. If you have to have it done in one go, you can have a lot of operations and be in theatre for a long, long time. But the thing about this sort of stuff, all this sort of cosmetic stuff, it's elective, it's planned. You don't have to have it all in one go. And so the question more is how much is right to have? How much can you have at one time? You can have an awful lot at one time. You can have your arms, your legs, your tummy, your breast, your face. You can have all this done at one go if you want, but you're not going to be very good post-op. So it's more about thinking about how you're going to recover. So, if you're having your tummy done, maybe your legs as well. But don't leave your arms alone, because, if you're having one side done, maybe leave the other side or something like that, having your breast and your tummy, maybe arms or something, and then leave your legs. You know what I mean? Just try and make it so that, you know what I mean? A little bit wrong, that, didn't it? But just try and make it that's comfortable for you. So be sensitive about it. Talk to your surgeon. Be guided by your surgeon, and just go with what's comfortable for post-op recovery. You got to eat. You got to walk. Got to breathe. Basics. Think of the basics. Look after the basics, Olivia. How long do breast implants last for? I had implants 5 years ago and was told they last a lifetime. I've now been told they last 10 years. What's the right answer, please? Ding dong. Look at that. Ding dong. Sorry. What's the right answer? God, if I knew the right answers, no right or wrongs in this world. You should know that by now. It's just opinions and views. Yeah. Well, implants are built to last a lifetime, and a lot of implants, certainly all the implants we use, have got a lifetime warranty. They're built to last forever. So that is the answer. They're built to last forever. But obviously, you can have problems. And the problems you can have is number one, rupture. Usually the warranty covers rupture if the shell fails and leaks and what have you. But the other one, probably more common than rupture, is capsular contracture. Now, capsular contracture is scar tissue around the implant, making it feel hard. Now, the implant's fine. So it's not actually a problem with the implant. It's a problem with the body's reaction to the implant. So that is probably the most common problem you're going to get. And that's why they can go hard over time. And I normally tell people it takes about 5 or 10 years for them to go hard. So that's where the 10-year thing comes in. Now, they don't have to be changed every 10 years, but around 5 or 10 years, they might start to go hard and you might want to have them changed. So having said they've got a lifetime guarantee or built to last forever, you might say, look, in 5 or 10 years, it's gone hard. I want to have it changed. And we might say, well, you don't have to have it changed. You can leave it. They say the first person to have the implants in, I should check whether this is still right. I've been saying it for a few years now, in 1960, whatever, has still got them in. So, 50, 60, what's that? I mean, yeah, 60 years. So, 1960, 50 years. Anyway, a long time. They're probably really hard, but you don't have to have them changed. We don't say you have to have them changed. You've got capsular contracture. They might well be uncomfortable. They go hard, they get uncomfortable. So you might want to have them changed. So if you're having implants, if you're thinking of having implants, well, you've already got them. So I just think positive and hope they'll be fine. But if you are thinking of having implants, you've got to factor that in. 5 or 10 years time, you might get problems with them. There are sometimes like polyurethane implants, which are less likely to go hard, so less likely to need changing. But still, factor in the possibility of needing an operation. And often when you need these other operations like capsulectomies and things, they're often more expensive, more invasive than the first operation. So something to think about. So yeah, they are built to last a lifetime, but around 5 or 10 years, you might start to get problems and you might want to have it changed rather than need to have it changed. So Olivia, I want tummy tuck breast implants and BBL. That's why I asked the question mark. Now, Olivia, I think tummy tuck and breast implants is fine. BBL, bit different. First of all, I don't do BBL. That's a Brazilian butt lift for those of us who are not familiar with the TLAs. So I don't do a Brazilian butt lift, but in general terms, having an operation on your buttock as well as your front, your tummy and your breast. Again, it's the turning thing. It's like the 360 tummy tuck. It's a turning thing. So I think that's a lot to have done personally. But again, talk to a surgeon. I think tummy tuck and breast is fine, but I'd probably have them done separately to the buttock personally. But I mean, it could be done. But can you imagine tummy tuck and breast? You're all bent over. You can't sit. When you had a tummy tuck, sitting is really good because you're taking the tension off your tummy. So if you had, whatever you had done to your buttocks and you can't sit, it's like, oh, flipping it. How do I get comfortable? I think that's too much personally, but I will go do them separately. But buttock one sitting and then tummy tuck and breast other sitting. Tummy tuck and breast is quite a big. What did you say? Tummy tuck and breast implants. I mean, that's quite a big operation in itself. Fiona, lovely to see you. Hope you're well. Good evening to you. Elaine's straight in with a question here. Is there a good age for a facelift? Do I wait till I'm over 50 for longer lasting results? Great question, Elaine. Great question. So, no, there's not a good age. Well, Elaine, I don't do facelifts, but we got Kurum at the clinic and another surgeon at the clinic who does do facelifts. Good age for a facelift. Really, good age for any sort of surgery really is when you've got a problem sort of thing. I think you've got to think about when you've got a problem and have it done then. I wouldn't have it done preemptively to prevent problems in the future, and I wouldn't wait to have it done later so the results last longer. I don't think you should either have it done sooner than you need it done or later than you need it done. Basically, what a facelift does is it resets you back to a better place, but you will continue to age. We can't stop time. We don't lock you in that time. So it just resets you back to a better place and you will continue to age from that place. So I guess if you the longer you wait, do you get longer lasting results? I think the results are going to last the same, although as you get older, your skin elasticity gets less. You've got to be careful with your skin, avoid too much sun exposure, avoid smoking, things like that to maintain a good quality skin. But the result lasts the same amount of time. But obviously, if you have it later, it sort of, sort of lasts longer. Like if you have it when you're 55, you're going to look, it's going to be better at 60 than if you have it at 50. Oh God, I need a graph. I need to draw a graph of this. So right. So you have it at 55. So you sort of need it. Can I get some help here, please? I need some help. I should have thought of this. So you need it at 50, right? And you're going to say, I'm going to wait till I'm 55 for longer lasting results. So you have it at 55. So that resets you back to a better place, but you're still going to age from there. So it will last longer than if you'd had it done at 50. So at 60, you'll be better than you would have been. Get me out of here, guys. Alarm. It's fire alarm. You'll be better than you would have if you'd had it at 50. But you'd have had those 5 years without the facelift, right? So yeah. So so have it when you need it, because those years 50 to 55, you would have looked better, or you would have, but you've waited till you're 55, so you're going to look better for 55 to 65 instead of 50 to 60. I'm not saying last 10 years, but do you get that? Do you get me? So basically, it lasts the same amount of time whenever you have it done. So have it done when you need it. Don't have it done too soon or too late. But obviously, the later you leave it, the less likely you'll have need of having another one. I have to reflect on that answer. Is that something? Maybe if you play that back, you can get a nugget of truth from it and see what I'm trying to say. I don't feel that came out very well, but anyway, Sarah. Whoa, big question from Sarah. A couple of people I know that have had tummy tucks, not with you, are not happy with the new shape. Thanks for pointing that out, Sarah. They've lost their waist and now are very flat, but have a more manly shape and have lost their curves. I understand that there is swelling for a long time afterwards, but how do you avoid this happening where you shape it, Sarah? It's interesting, I was thinking about this, sort of thing I think about. I was thinking about this in theatre the other day. You got a wound and you stitch it, and they're stitching it and they're stitching it. I was doing a tummy tuck not today, yesterday, and I was thinking about this because anyone can stitch a wound. Well, it's within reason. But what you try and do as a plastic surgeon, often when it comes to finishing an operation, when you come to closing the wound, that's the end of the operation for a lot of surgeons, and they take their gloves off, walk out, wait, let the registrar stitch up, or try and that's it, finish the operation quickly, get it done. With plastic surgery and cosmetic surgery in particular, closing the wound, if you like, is the operation. It's where the action happens. And so what you're trying to do is you're always trying to bring it in immediately to try and get definition on the waist and to narrow the abdomen and get that contour. And it's something that we try and do when we do the surgery to get a good shape to the abdomen. So that is part of the surgery. So yeah, absolutely, there's swelling for a long time. So how do you do that? Where you try and medialize everything, you try and bring it in from the sides to try and pull it in to get good definition on the waist. Certainly combining it with liposuction can help that. But when you're doing the tummy tuck, that is something that you do to try and make a better shape. So yeah, it's part of a tummy tuck. That's why you got to look at people's before and afters. Try and get someone who you think's good. Fiona, what is recovery time for a tummy tuck? Big op, Fiona. A tummy tuck is bent all up double, in hospital for a couple of nights, drains, walking all bent double for a bit, off dressings, what have you, abdominal binder, dressings on for a week. After the first week, you come back, we take those dressings off. Normally don't need a dressing after a week. That first week, you're not going to be up to much. You're going to be bent over double. You're going to be relaxing at home, watching a bit of telly, keeping moving because you don't want to get blood clots and things. Second week, you're going to be feeling better. You're going to be pottering around the house a bit more, maybe doing a bit of, if you can work from home, maybe doing a few emails and stuff in the second week. I wouldn't really be going to work and stuff. 2 or 3 weeks normally for driving, and therefore for going back to work. Particularly if you're employed, I would say 3 weeks to be safe. If you work for yourself, maybe after two to 3 weeks, you'll be going back to work, as long as you can sort of knock off early if you're feeling a bit uncomfortable and a bit sore. But probably 3 weeks would be safer to say, to start getting back into things, driving, getting back to work, things like that. But even at 3 weeks, still feeling a bit weird, scarring, be a bit red, and all feeling a bit, a bit swollen, and you might be a bit sort of bit uncomfortable when you're walking. And then probably about 6 weeks before you're doing the gym and running and impact sports and um, activities, lifting, heavy lifting and things. And it's 3, 6, 12, 18 months for the scars to settle, numbness, funny feelings, shape, swelling, blah, blah, blah. So it takes a good long time. And all things start to settle at 3 months, I normally say, but it can take 6, 12, 18 months for it um, to settle. Good question. Thanks for that, Fiona. Elaine understands my sentiment. Thank you, Elaine. And I'm sorry if I got getting all sorts of trouble on YouTube with my rambling. Keep on saying I'm rambling with my questions. I'm not doing myself any favors tonight, am I? God. We get your chick PMSL. Nope. No idea what that means. We get your chick PMSL. PMSL. Okay. I'd like that comment if I could, but I'm not on the I'm on my dashboard. But yeah, get right back at you, Ali. Right back at you, Ellie. So, how do you do long breast? Where are we up to? Is it possible to have a breast reduction sealed with glue instead of stitches? Yes, it is. Now, we don't, well, say we, plastic surgeons tend not to use much glue. Glue is something that, when you're in A&E and you cut your head, or especially if your child cuts your head, they glue it. So, what's PMSL? Why does everyone do PMSL? Oh, PM. Oh dear, Is that what PMSL is? Oh, I'm glad I didn't know what that was. Ellie, really? What are you writing that sort of thing for? Dear, oh dear. I thought that's LOL, isn't it? Is that is that a thing? PMSL? Oh, I don't know. I'm learning. I don't know if I want to be exposed to this sort of. What are they? Anyway. Oh dear. I tell you what. Right. Thank you. Thanks for So, yeah, glue is usually in A&E and stuff where your child cuts their head and it doesn't really matter what the scar looks like because it's in their hair and things, and they can't really stitch it properly because the child thing, so you can glue it to help bring it together. Plastic surgeons, we take a long time on the closure, and we want to make the closure right. And so, personally, for a wound closure, I would not use glue. I would use sutures, because when you're putting a suture in, you can adjust each suture and you can get the wound aligned and effaced properly. You have to efface the wound. You have to bring it so the wound's sort of cut like that. You have to bring the edges up like that, everted like that. You have to invert the wound so you get maximum contact, so the wound will heal. You don't want it inverted. If it's inverted and you've got sort of skin against skin, take the stitches out, it'll open up. So you have to take care when you're suturing a wound to evert the wound, get good contact to make sure the wound heals nicely. That's difficult with glue. Now, so, and I understand in breast reductions, tummy tucks, there's quite a lot of stitching, and so people are looking for ways to speed things up. Now, sometimes we do use glue to seal a wound once we've stitched it. So some people will do that. They will stitch it and make it all look fine, and then they'll put glue on it in order to stop using a dressing. So they just put glue, and then they won't use a dressing. So that's more of a thing that plastic surgeons might do. So actually, your question has said sealed, doesn't it? So that's to seal the wound, but that's as well as stitches. So that's sealing the wound rather than closing the wound. So we tend not to close wounds with glue. We would use stitches because we want to make control how how we close it, but we might use it on top, or some might. I tend not to, but some surgeons might use it on top as sort of a waterproofing layer. I've had a cholecystectomy. Will this prevent me from having a TT? Good question. Now, for those of you who don't know, cholecystectomy is a gallbladder removal, and there's nowadays we do them with telescope, laparoscopic surgery. So laparoscopic surgery, absolutely no problem. But I think the reason that this question has been asked because the old-fashioned way of doing it with what's called a Cocker's incision, which is a big scar here, big scar here, big long scar underneath the line of the ribs, and it's called a Cocker's incision. And that's how they used to do what's called an open cholecystectomy as opposed to a laparoscopic cholecystectomy. So if you have a Cocker's incision, if you have a big scar at the top of your abdomen, that is a relative contraindication to having a tummy tuck. So there's relative and there's absolute contraindication. So an absolute contraindication means forget it, you're not having a surgery, that's not it's not a goer. Relative means that it's like PG, parental guidance. It's advisory. Um, so it is, the reason is because of the blood supply. Because if you have a big cut there and then you take a big bit your tummy tuck and then pull that down, you've got your tummy tuck scar and you've got a scar above it, and that scar might prevent the blood supply getting in and might affect the wound healing. Might be easier for me to demonstrate that on someone rather than how I've said it, but it basically affects the blood supply to the bit of skin between where the scar, the old Cocker's incision is, and your new tummy tuck scar, because that'll be like a railroad, two scars next to each other. The older the Cocker's incision is, the better. And if you've got a Cocker's, it'll probably be old because it's very rare to have a open cholecystectomy these days. And there are ways we can work around it, particularly if you've got a big abdominal apron and there's going to be quite a bit of skin there. And sometimes we can look for perforating blood vessels to supply that bit of skin between the scars and try and get around it. So we can get around it. So it's not an absolute no, but it is something we would worry about and we need to be aware of. And we'd have to talk to you about that. There's increased risk of getting wound healing programs. I've just read the comment that says program. Sorry, wound healing problems. I love this program. That's me. I've learned a lot. Oh God, Olivia, you're making me feel better. Oh, I don't know. I don't know whether I should do it. Should I do it sort of pre-recorded? I think I'd do a better job if I did it pre-recorded. Sometimes I do think I go a bit off tangent, but anyway. That's very kind, Olivia. I will take that away with me. Thank you for your kind words. What was I saying? So it's a relative contraindication, a cholecystectomy, a big scar, but not absolute. Someone you'd have to talk with your surgeon too about. Not even speaking English anymore. Something you'd have to speak to your surgeon about. Yeah. So it's a good question, and it is something that you have to be aware of. Blimey, O'Reilly. I mean, look at this. I'm going to put it on. Can we screenshot that? All right, screenshot. Ready? Next one. Need a screenshot on that one as well, please. And very entertaining. Look at this. It's very entertaining, this. There you go. A lot. Very entertaining. That's what we want. Bit of positivity. Can you just tell everyone the training you've undertaken over and above what a general surgeon does, please? Right. Okay. So this is one of the problems with this stuff. It's not very clear, is it? So a general surgeon is actually a specialist. General surgery is a specialty of surgery. So a general surgeon is not necessarily sort of less trained person. They are specialists in their own right. So there's some specialties in surgery, and general surgery is one of them. Plastic surgery is another one. ENT, cardiothoracics, orthopedics. There's different ophthalmology, obs and gynae. There's different surgical specialties, and general surgery is one of them. So it's not like general surgery is sort of less of a thing than a plastic surgeon. They're just different. They've been trained in different things than plastic surgeons have been trained in. General surgery is very much bowel. It's bowel, GI, upper GI, lower GI, also glands, so breast, thyroid. But in terms of breast, it's more the breast cancer side of things. So I often say to people looking for a breast surgeon, I'm not a breast surgeon. I'm a plastic surgeon. A breast surgeon is traditionally a general surgeon who has then gone on to specialize in breast. But that is someone who deals with breast lumps, breast cancers, breast pain, mastectomies, biopsies, MRIs, working with chemotherapy, radiotherapy. I just, as a plastic surgeon that specializes in breast, I just do the reconstruction and I just do the cosmetic side of it. I don't do any of the excisional side of it and the sort of lumpectomies and the mastectomies. So a general surgeon is a specialist in their own right. So basically, what you look for is a surgeon. So when you have surgeons, so when I did it, it was called FRCS. Nowadays, it's called MRCS, Fellow of the Royal College of Surgeons or Member of the Royal College of Surgeons. That's the sort of basic surgical qualification that a lot of people have got, and that they think that they're a surgeon. That's when you get to call yourself Mr. So with doctors before, and then when you get to become a fellow or a member of the Royal College of Surgeons, you get to call yourself a Mr. And then you're a surgeon, I guess. You're a member or a fellow of the Royal College of Surgeons, and then you call yourself a surgeon. But that's actually quite a basic qualification. In order to get that qualification, you have to show that you can do an appendicectomy, and it's a pretty basic thing. You're at quite a low level when you're working in the NHS. You're normally as an SHO, a senior house officer. You're not a registrar. These are different levels of surgical training. So it's quite a low level of surgical training. You're not performing any surgery unsupervised. You'll always be supervised by a consultant. Now, if you want to become a consultant in the NHS, if you want to become trained in a specialty, then you then have to go on and do subspecialty training. And that can be in general surgery, or that can be in plastic surgery, or as I say, orthopedics, or one of the others. And in plastic surgery, it's 6 years. So there's 6 years specialist training. They're quite hard to get the jobs, the post, to get into one of those 6-year posts. And at the end of the 6-year post, there's an exam, which leads to a qualification called a CCST, a certificate of completion of specialist training. And then you get on the specialist register with the GMC. And then all doctors should be registered with the GMC. If you work at a clinic and they say all our doctors are registered with the GMC, if you're like saying, yo, of course, you have to be registered with the GMC in order to practice medicine. That's a given. So being registered with the GMC is a given, but being on the specialist register with the GMC is a bit different. And you can check that on the GMC website. If it just says they're on the GMC, but if they're not on the specialist register, then they haven't done subspecialty training in anything. So you have to do subspecialty training. Once we've done that subspecialty training, then you get the letters after your name: FRCS Plast for plastic surgery, FRCS Gen, GEN for general surgery, or for orthopedic surgery, or whatever. So that is the difference. And so the priorities of training are different for different specialties. Like, for instance, general surgery. People say, like, they have the laparotomy, they have a tummy, they have stomach cancer or something. They say, look at the scar of that. It doesn't look very good. It's got hash marks on either side of it. Now, when you're doing general surgery, if you're specializing in bowel, things like that, you're really focusing on what you're doing to the bowel. And they don't really, in a way, you don't really want to spend a lot of time stitching up. Patients are often ill. You just got to get the wound closed, get it healed. Cosmetic issues are not a priority for them. Plastic surgery, the priority has always been form and function. It's all form and function. We do a lot of hand surgery, and we a lot of tissue handling, treatment of wounds, getting wounds healed, how you handle tissues, how you maximize healing of wounds, and like I say about the suturing and what have you. Played a lot of that in plastic surgery. So it's a different type of training. So a general surgeon might still be trained, but not in plastic surgery, in general surgery. Is that? It's not clear at all, Khan, and I wish it was clearer, but it's not, and that's why I wrote my book. Can you see it? Not bounce. I haven't read that yet. Not bounce. Anyway, I wrote my book. Never accept to lift the changes. How to choose the best plastic surgeon for your cosmetic breast surgery. Available in all good bookshops. I don't think it is actually. I don't think it is available in bookshops. In fact, I know it's not. It's available on Amazon though. Or my website, neveraccepttoliftchanges.com. So, I'm tired. You know what? It's been all go today. Olivia, look at me. I've been running around today. I tell you, I've been catch up all day. I had to get back home because my wife's gone out to some show, so I had to get back home to do this because I would have done it in theatres otherwise. But running round, I'm in charge of the boys next door. I can hear them. I think they're all right. Some, I don't know, am I a responsible parent being in charge while I'm doing this? Anyway, don't want to dwell on that. They're quite old. They'll be all right. I'm when Fiona, when did surgeons start using dissolvable stitches? I was thinking back to my 2000 op, not with you. I had to have them out, which hurt. We've used dissolvable stitches for a long, long time, Fiona. Um, but there are pros and cons, as with anything, of dissolvable and non-dissolvable. So non-dissolvable sutures, it's predictable when you can take them out. So we use non-dissolvable sutures for things like the face. When you want to get a really good scar and you want to make sure that stitch comes out of 5 days or 7 days, you will use non-dissolvable sutures. But it can be a bit uncomfortable to take them out. So on the trunk, we tend to use dissolvable sutures on the trunk. But it does go a bit red while that stitch is dissolving. It does make it a bit more inflamed and red while the stitch is dissolving. So, as I say, pros and cons. But yeah, certainly in 2000, they had dissolvable sutures. I don't know how long they've been going, but they've been going for a long time, Fiona. But it may be a good reason why your doctor didn't use dissolvable ones. You might want to get that stitch material out so your healing would be better. So you don't have that foreign body in there of the suture. So there are benefits in not using a dissolvable suture. Khan always recommends my book. Big up yourself, Khan. You're a ledge. You know that. Thank you for that. I should give you commission, but I think I get about, well, I give it free except for postage, don't I? So I don't get much money myself for it. It's not going to be able to retire on it, but thank you. Thank you. Get the message out there, sister. Let's do this. Right. 10 weeks post-op from a breast augmentation. We've done that? No, we haven't. Cholecystectomy, we've done that. Right, let's get into this now, team. Let's get into this. What do you got? I'm 10 weeks PO from a breast augmentation and TT, and I feel really down. PMSL. No, I don't PMSL off that. Oh, God, that's inappropriate, wasn't it? So I was just using the abbreviations. Sorry about that. Oh, God. So I'm 10 weeks post-op from breast augmentation and tummy tuck. I feel really down. I normally so upbeat. Is this a normal reaction? Yes, it is. 10 weeks is nothing, and a tummy tuck and breast augmentation is big. It's a big op, big surgery. I think people think that cosmetic surgery is not big surgery. They think it's all lunchtime, this and that, and it's insignificant. It's not. It's significant. It's a big deal, and having both of those done is a big deal. It's a long anesthetic, and it will knock you back for months. Don't put yourself down. It's totally normal. Everyone feels tired, jaded, and if you try and do more, you're just going to delay your recovery and make it slower. Go with it. Give yourself a body a chance. Give your body a chance to relax and heal, and take it easy. By all means, move about and things, but don't worry if you're feeling tired all the time. If it still hurts, if it still feels numb, or funny feelings, swelling, and all that sort of stuff. As I say, I normally say to people, with any operation, it starts to settle about 3 months. For a breast augmentation and a tummy tuck, that's a big op, So it starts to sell about 3 months. So what are you? You're just over 2 months. Hadn't even started to sell yet. Only starts at 3 months. So you're well on track there. Don't worry about it. Don't feel down. Go with it. Accept what you've had done, and just let your body heal and give your body a chance to heal. It's totally normal. What's the highest BMI for a tummy tuck? What is the highest what's the highest BMI you'd recommend for a tummy tuck? I'm 38 and desperate to have it done. I'm assuming you're not 38 years old, your BMI of 38. Two things with a tummy tuck. First is the absolute value. And if you ask me for an absolute value, I'll tell you 30. That's my answer to that. Now, if you want an absolute value, 30 is the absolute value because they've done studies and they say, look, if your BMI is above 30, then you've got a slightly increased risk of complications and things, so you're more likely to have problems. Now, that's the absolute value. The second part to that answer, when everyone says, what BMI do I need to be? I say you need to be stable and comfortable with your weight. If you're not stable and comfortable with your weight, don't have it done either way, but particularly if you want to lose weight. So people say, I've got this big apron and I can't lose weight, I can't jog in the gym, and I can't run and all that. But if you have surgery now and then you lose a significant amount of weight, you may get redundant skin and you'll have a worse result. You'll have a better result if you lose the weight first. So the absolute value is 30, but even if your BMI is 29, if you want to lose weight before the surgery. Now, that doesn't mean I won't operate on people with a BMI above 30, because I understand a lot of people, particularly people who have lost a lot of weight, a BMI of 30 is not realistic. So it's not an absolute written in stone thing. In the NHS, you'll find it's written in stone. It's probably 25, or probably won't even do a tummy tuck. But it's not written in stone, because I understand some people just say, look, that just means I'll never have a tummy tuck because I'm never going to be 30. Now, I've got to say, I think 38 is too high. I do think it's too high. I talked earlier about relative and absolute contraindications. I reckon 38 is getting on for an absolute contraindication. Getting on for it, maybe not, but it's too high. You're going to get a complication if you have a BMI too high. It's not going to be safe. DVT, pneumonia, chest infection, wound healing problem, all sorts of things. Particularly also if you're not happy with your weight. And I know it might be hard to hear because you may be struggling, but I think you really need to lose weight first. And you really need to look. What we're looking for is a drop of weight, and for you to say, look, you know what, I'm happy with my weight now. I don't want to be any less. When I get less, lose weight, I go gaunt. I don't like my body. I don't like how I look. And that might still be a BMI above 30. And if that is the case, then we can talk about it. You're still having a higher risk of complications, but that might be right for you. I do think 38 is too high. So I think it should be lower than that. But I don't have an absolute. Well, I do have an absolute. Oh my God, this is my last question. I do have an absolute value, which is 30, but you might never get there. And that's fine if you don't get there. But, you need to be moving towards it. That's my last question, guys. I didn't realize that's rushed up on me. Yeah, so good luck with your weight loss there on that one. And anyone got any more questions? That's a bit of a roller coaster. I think you'll agree. Got through it though. Got through it. I don't think I embarrassed myself too much. Did a little bit earlier on, but I think we'll gloss over that. And all in all, got through it. Maybe didn't do it as slick as I could. Practice a bit on those right age for a facelift questions, but getting there. So I am gonna. Khan says thank you. What I love. Thank you, Khan. That's what I'm gonna say to you. No, I'm not even gonna say it. I'm gonna type it. Thank you. Thank you. Is that? Oh God. Is that putting? Oh my God. Sorry. I tried to. I think that was the wrong. Was the wrong emoji. I think I wanted to point. I'll just. What should I do? Pray. I'll do pray. Thank you. Yeah, that's probably a bit safer. Yeah. Dear, oh dear. Sorry about that. That looked a bit wrong. Julia says, well done. Oh, Olivia says, well done. God, you're too kind, guys. You're too kind to me. Thank you. And I've got to say, looking at myself, do I need a haircut? I mean, I know there's not much there, but it looks a bit fluffy up there. I thought I'd go Jason Statham on it, just totally, Anyway. Was that the wrong emoji? Oh my God. Was it? Oh, I don't. Is there any way I can retract this now? Is it on Facebook now forever? Oh dear. Just when I thought it was going, I was about to go. Oh dear. Oh dear. Well, I do apologize if I've offended any viewers with my emoji use. I meant it to be pointing up. I said thank you is what I meant to do. And I thought that was the emoji I was using. And if I have offended anyone and used the wrong emoji, it was totally in not what I meant to do. So thank you all, and I better go before I cause myself any more trouble. Please, if you have any more questions, get in there, ask some questions. I'll try and do a bit more research next time and get slick on it. Getting there, but that's Julia. You understand, don't you? You understand that was meant in good faith. That was a finger. That was like thank you. I'm going to leave before I get into any more trouble, and I'm going to say good night all, and I'll see you next week for the same again. Get your questions in. Ciao.